All right, so we're continuing with patient assessment, and we're at history taking. So history taking provides detail about the chief complaint and the patient's signs and symptoms. It also includes demographic information, the date of the incident, patient's age, gender, race, past medical history, and current health status. This is a very weak area for EMTs in Jamaica, so it's something that we definitely need to work on. Most EMTs can, well, I can't even say most, but a few EMTs are able to obtain a sample history to some extent. Um, the the issue is when it comes to obtaining the OPQRST. So the sample collects a broader, collects more information. It's not very specific. It covers a wide range. The OPQRST gets information on the presenting problem. So that's the purpose of our OPQRST. It's to gather information on the current issue. Not all the letters will be applied to every medical condition, but every medical condition will require certain aspects of the OPQRST, and that's where the weakness is. And some persons, when they collecting information on the sample, they're not considering the information that they're collecting, so they don't know when to follow up and what type of questions to use as follow-up. So that's where the issue is. Your ability to collect information is extremely important to the medical patient. It's not exclusive to the medical patient, but it's very important to the management of a medical patient. Now, investigate the chief complaint, make introductions, make the patient feel comfortable, and obtain permission to treat. Ask few simple and direct questions. Refer to the patient as Mr., Miss, or Mrs. using the patient's last name. Ask open-ended questions. If the patient is unresponsive, patient information and clues about the incident may be obtained from family members present, a person who may have witnessed the situation, bystanders, medical alert jewelry, other patient medical history, documentation. Use the OPQRST mnemonic to assess symptoms. This will provide information on the presenting problem. The OPQRST is not exclusive to pain. You can certainly ask all the letters for pain, but it's not exclusive to pain. Any medical patient that you have, you need to think about which aspects of the OPQRST would be appropriate to ask that patient. So onset is when the discomfort began, provocation, what makes it worse, palliation, what makes it better. Ask the person to describe the discomfort. Region, radiation, let them pinpoint where, ask them if it radiates. Severity, give them a pain scale, what would be the lowest, what would be the highest. Timing, does it come and go, is it constant? Identify your pertinent negatives. These are symptoms that you would expect to be present, but they are absent. So you have a patient who has a cardiac history, complaining of palpitations, shortness of breath, but doesn't have any chest pain. chest pain being absent would be a pertinent negative. Now, once you have obtained information on the presenting problem, and this is something that you need to write out and learn. So each medical emergency that you cover in your textbook or the EMT curriculum or in your protocol, you need to think about which areas of the OPQRST would be appropriate for that medical problem and what are the questions that I would need to consider. After the OPQRST, you want a sample. Use the mnemonic sample to obtain the following information. So you have your signs, your symptoms. The signs and symptoms is where your OPQRST comes into play. A, allergies. Is a patient allergic to any medication? Is a patient allergic to any food? M, medication. Is a patient on any medication? If they say yes, which medication they're on? Why are they taking this medication? When was the last time they took the medication? Is it available for you to examine? Pertinent past medical history. Does the patient have any past medical issues? Last oral intake. When was the last time the patient had something to eat? And if necessary, what exactly did they had to eat? E, events leading up to injury or illness. What exactly were they doing when the injury or illness occurred? So your OPQRST and your sample. Very important to medical patients. It don't mean that it's only medical patients you're gonna ask these things. You can ask trauma too. Now, critical thinking in assessment. As EMTs, you need to be able to think critically. That's very important when you have a patient that is in trouble, where the ABCs are compromised. In order to be able to do that, you must be able to gather information. So you need to seek facts. Facts is what you're trying to find. Evaluate and considering what the information means. So when you gather the information, what does it mean to you? Now, based on the meaning of the information to you, you will then organize a treatment plan for your patient. Now, in order for you as an EMT to be able to think critical under stress, your fundamentals must be solid. And most EMTs, if not all the EMTs who are currently practice, do not have solid fundamentals in Jamaica. In order to have solid fundamentals, you must have a decent understanding of anatomy and physiology. So there must be base knowledge in anatomy and physiology. If you don't know the system that's being affected or it functions, then you're gonna have problems assessing and managing that system if something is wrong. So that must be present. Then there must be a solid foundation, to assess a patient's airway, how to manage the patient's airway, how to manage the upper and lower airway, how to manage circulation, and how to manage a patient in shock. So the fundamentals must be solid. And one of the things that is necessary to maintain solid fundamentals is to be up to date with what is happening in your present field of practice. So if you're not up to date with what is currently going on, then you're gonna have problems with your fundamentals. And it's really up to the responder. It's up to you as a responder if you're working in the field, whether you want to develop strong critical thinking skills or not. What I do know for sure is if a responder doesn't have strong critical thinking skills, the patient will ultimately suffer. And then we come to the debatable question. So if you cannot assess and manage the patient appropriately using critical thinking skills. How is it that your response will be more beneficial to the patient than if the patient just call a taxi or make a family member carry them to the hospital? That's a very important discussion that needs to be had. Now, taking history on sensitive topics. So you can have your patients who overuse alcohol and drugs. Signs may be confusing, they can be hidden, or they can be disguised. The patient may deny having any problems. They may deny drinking no more than 2 beers. You can't rely too much on their history. Do not judge the patient and be very professional in your approach. There, you can have patients who have been physically abused or violence is involved. When you have these patients, when you have these patients, report all physical abuse or domestic violence to the appropriate authorities. Follow your local protocols. Do not accuse, instead immediately involve law enforcement. Can have patients where you need to obtain sexual history from. Consider all female patients of childbearing age who report low abdominal pain to be pregnant. Ask about the patient's last menstrual period. Inquire about urinary symptoms with male patients. When appropriate, ask all patients about potential for sexually transmitted diseases. You can have the patient that is silent or silence. This can be an issue. Patience is going to be extremely important for these patients. Use a closed-ended question that requires a simple yes or no response. Consider whether the silence is a clue as to what is wrong with the patient. So, is the silence linked to the patient's chief complaint? You can have the patient that is overly talkative, and that can be attributed to caffeine consumption, which is a stimulant. They can be nervous, they can have taken cocaine, crack, or methamphetamines, which are all stimulants, or they have underlying psychological issues. You can have patients with multiple symptoms, usually a geriatric population. Prioritize the patient's complaint as you would in triad. So when you have these patients, collect the complaints and sort them out based on priority. What do you think is the priority? Whatever you deem to be the priority, that's where your assessment will be focused. Start with the most serious and end with the least serious complaint. Anxiety. So you're gonna have those patients. Some anxious patients will show signs of psychological shock, which include pallor, diaphoresis, shortness of breath, numbness in the hands and feet, which you will see that with patients who are hyperventilating, they tend to get numbness in the hands and feet. Dizziness or lightheadedness, loss of consciousness. Anger and hostility. Friends, family, or bystanders may direct their anger and rage toward you. Try and remain calm, be reassuring and gentle. If the scene is not safe or secured, then your personal safety and the safety of your crew members become your priority at that point. The intoxicated patient, intoxication. Do not put an intoxicated patient in a position where he or she feels threatened. Potential for violence and physical confrontation is very high with these patients. Alcohol dull a patient's senses. The crying patient. A patient who cries may be sad, they might be in pain, they might be emotionally overwhelmed by the situation. Remain calm, be patient, reassuring, and confident. Maintain a soft voice. Depression. This is among the leading cause of disability worldwide. Symptoms include sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, and a decrease in energy level. Be a good listener. Can have patients who display confusing behavior or history. They can have underlying medical conditions that are causing this. Conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drugs could alter a patient's explanation of events. Older patients can have dementia, delirium, or Alzheimer's disease. Alzheimer's disease. Patients with limited cognitive abilities. Keep your questions very simple and limit the use of medical terms. Be alert for partial answers. Keep asking questions. You may have to rely on the presence of family members or caregivers and friends to assist you with obtaining answers from these patients. Cultural challenges. Do not use medical language. Patients may prefer to speak with healthcare providers of the same gender. Gain the assistance of the patient's friends or family members, if possible. Enlist help for healthcare providers of the same culture or background, if possible. Language barriers. Find an interpreter, if possible. If not, determine if the patient understands who you are. Keep questions straightforward and brief. Use hand gestures. Be aware of the language diversity in your community or primary service area. Hearing problems. Patients with hearing problems. Ask your questions slowly and clearly, and ask in a position where they're able to read your lips. Use a stethoscope to function as a hearing aid. Learn simple sign language to help with communication. Use a pencil and a paper. Visually impaired. Identify yourself verbally when you enter the scene. Return any items that have been moved to their previous position, because they normally have their environment set up in a particular way in which it is easy for them to navigate based on where things are. Explain to the patient what is happening in each step of the assessment of the vital signs, and sometimes they will have a dog, a guide dog. Now, that would be the end of the history taking phase. So the most important points to note with history taking. When it comes to history taking, we're going to gather information from the patient, family members, bystanders, or the scene. If the patient is not able to give you appropriate information, your vital signs should include pulse oximetry, pupil response, blood sugar. When gathering information, especially for your medical patient, you need to obtain information on the presenting problem, which is your OPQRST, and you need to gather a wide range of information, which is your sample history. And most important, well, not most importantly, but you also need to think about your patients with special challenges. So patients that you're going to have some amount of challenge obtaining information from. Now, the next phase or the next part of the patient assessment Now, the secondary assessment may be performed unseen in the back of the ambulance en route to the hospital or not at all. The purpose is to perform a systematic physical examination of the patient. It may be a systematic head-to-toe secondary assessment or an assessment that focuses on an area or system of the body. And you can move aspects of your secondary assessment into your primary assessment. It depends on your mechanism of injury or whether or not a patient can tell you what's happening. So the main purpose of the secondary assessment is to pick up issues or injuries that have the potential to be life-threatening that may have been overlooked because you were focused on your primary assessment. During this phase, we will also do our recorded vital signs. And the recorded vital signs that we obtain at this point, we will now compare it to the findings of our primary assessment. And that is why it is very, very important that you do a proper primary assessment. So in the primary assessment, the findings was before you provided treatment. In your secondary assessment, your vital signs that you're obtaining now will tell you if your treatment is working or it's not working. So you have something now to compare. There is a comparison, but if you didn't do a proper primary assessment, what are you going to compare it to? Are you going to know what is working? Are you going to know if what you have done is effective? That's the purpose of being thorough with your assessment and reducing gaps. Now, how and what to assess? We will inspect, or there is inspection, look at the patient for abnormalities, palpation, touch or feel the patient for abnormalities, auscultation, listen to sounds a body makes by using a stethoscope. Best way to listen to lung sounds. You will use the mnemonic DCAPBTLS. This is something that I would expect you to know the meaning of at this stage. Compare findings on one side of the body with the other side when possible. So bilateral. Systematically assess the patient. The goal is to identify hidden injuries or identify causes missed during the 60 to 90-second exam during the primary assessment. Your focus assessment. Perform on patients who have sustained non-significant MOI or responsive patients, typically based on the chief complaint. The goal is to focus your attention on the body part or systems affected by the priority problems. Now, if we're going to assess the respiratory system, we will expose the patient's chest if it is appropriate. We will look for signs of airway obstruction. We will inspect for symmetry. Does the right side of the chest matches the left side? We will listen for lung sounds, and a lot of EMTs do not know where to place the stethoscope when listening for lung sounds. Ensure that you review YouTube videos for placement before coming to your practical session. Measure the respiratory rate. Look for retractions and increased work of breathing. For the respiratory rate, you will count the rise and fall for 30 seconds and you multiply that by 2. An adult will normally breathe at 12 to 20 breaths per minute. The younger the patient, the faster they breathe. If the breathing rate is irregular, then you do it for a full minute. When you're obtaining a breathing rate, the patient should not be talking to you at that point. One of the most commonly guessed vital signs is the respiratory rate. Don't guess, do the actual checks. Now, once we have looked at the rate, we will look at the rhythm. And I mentioned this previously. Rhythm is consistency. You're looking at the consistency of the chest rise. Is it regular or irregular? Regular, the time from one peak chest rise to the next is consistent. Irregular, the respirations vary or the rate changes frequently. After we have ascertained the rate and rhythm, we will look at the quality. And when we're looking at the quality of a patient's breathing, we're looking at whether there is muscle use present, whether abnormal sounds are present, is it positional, what is the pulse ox telling you, is there adequate rise and fall? Sorry, what is the pulse ox telling you? Why am I going into rise and fall? So quality is muscle use, abnormal sounds, positional pulse oximetry. So the quality of breathing. Normal breathing is silent. Breathing unaccompanied by other sounds may indicate a significant respiratory problem. Then we need to consider the depth of breathing. Is there adequate tidal volume? Is there visible chest rise bilaterally? So depth of breathing, the amount of air the patient exchange depends on the rate and tidal volume. Breath sounds, you can almost always hear breath sounds better from the patient's back. Again, ensure that you practice how to obtain proper breath sounds before you come to your practical session. No, I'm not telling you that every patient is going to require breath sounds. You need to know when it is necessary, for sure. So I don't expect you to listen for breath sounds when it's not necessary. But when it's necessary, it needs to be done properly. What are you listening for? So you're listening for normal breath sounds, snoring breath sounds, which you should be thinking about the tongue, if that's the case. Wheezing breath sounds, you should be thinking about lower airway problems or lower airway constriction. Crackles on rhonchi, you should be thinking about fluid in the alveoli, and that fluid can be thick or it can be thin. Stridor, you should be thinking about upper airway obstruction. So the sounds that you're hearing, what does it mean, is important. The meaning of these sounds is very important. Now with the cardiovascular system, look for trauma to the chest and listen to breath sounds. Consider the pulse, respiratory rate, and blood pressure. You can also listen to the heartbeat. That might be appropriate as well. Pay attention to the rate, quality, and rhythm of the pulse, or rate, rhythm, and strength. Consider your findings when assessing the skin. Check and compare distal pulses. Consider auscultation for abnormal heart sounds. For the pulse rate, normal resting pulse rate for an adult is between 60 to 100 beats per minute. The younger the patient, the faster the pulse is going to be. If the pulse is below 60, it's considered a bradycardic pulse. If it's over 100, it is considered a tachycardic pulse. If the pulse is irregular, you will obtain the rate for a full minute. Now, you can now use 15 seconds to obtain a pulse rate. So you have the option of using 15 seconds for the pulse rate and multiply it by 4. If you're not comfortable with your 4 times table, 30 seconds multiplied by 2. If it's irregular, that should be a light bulb moment for you. So if a patient has an irregular pulse, do it for a full minute. But you should know at that point that this patient has an abnormal heart rhythm. Now the pulse quality. Describe a stronger than normal pulse as bounding. A pulse that is weak and difficult to feel is described as weak and or thready. So you look at the rate, you can look at the rhythm again. Once we're looking at rhythm, we're looking at consistency. So is it regular? The interval between each contraction should be the same. The pulse should occur at a constant regular rhythm. Irregular, if the heart periodically has an early or late beat, if a pulse beat is missed. And for the blood pressure, this is the pressure of circulating blood against the walls of the arteries. A drop in the blood pressure can be linked to, can be not enough fluid, which is blood or plasma present. It can be the blood vessels, the veins are too dilated, or it can be the arteries are too constricted, or it can be there is a pumping issue. Once blood pressure starts to fall, pulse rate increases. One of the things that you need to also obtain from your blood pressure is the pulse pressure, not the pulse rate, the pulse pressure, which is the difference between the systolic and the diastolic pressure, which is an indication of how strong the heart is contracting. And it can be an indication of shock, and it can be an indication of a patient for a patient who is at risk for stroke. A normal pulse pressure should be between 40 to 60 millimeters of mercury. If the pulse pressure is below 40, the contraction of the heart is weak. If it is above 60, it is too excessive. Now, decreasing blood pressure is a late sign of shock. Abnormally high blood pressure may result in a rupture or other critical damage in the arterial system. We're not going to go through the components of a BP cuff and how to obtain a blood pressure. That is something at this stage I would expect you to be very comfortable with. Just understand that what we will be looking for, regardless of what you have been practicing, is we are looking for a blood pressure being obtained using the palpation and auscultation method. So we're looking for a combination of that. Anything outside of that that is done will result in a fail. So just keep that in mind. Normal blood pressure. Hypertension is blood pressure that is lower than normal. Sorry, hypotension is blood pressure that is lower than normal. Hypertension is blood pressure that is higher than normal. And the normal range is listed in table 10-7. And these are charts that you should have in your protocols or guides in your protocol. All right, now for the neurologic system. Neurologic assessment should be performed with any patient who has changes in mental status. A possible head injury, stupor, dizziness, drowsiness, syncope. Neurologic assessment evaluates the level of consciousness and orientation. You will be using the AVP scale if it is appropriate, and you will be using the Glasgow Coma scale or GCS score if it is appropriate. And the GCS is more commonly used at this stage. You will examine the pupils. So the pupil is the black center portion of the eye, normally round and of approximate equal size. In the absence of any light, the pupils will become fully relaxed and dilated. So you need to check the pupil reaction. Pupils can be pinpoint, full blown, or unequal. So if a light is shined and the pupils are pinpoint, shined in the eyes and the pupils are pinpoint, then you should be thinking about the possibility of a opioid or opiate overdose. So you need to consider the history for this patient. If the pupils are fully dilated, can be a sign of death, can also be a sign of head injury issues, or it can be a sign of barbiturate or barbiturates overdose. The patient has unequal pupils, unless they have been born with the pupils that way, you should be thinking about some type of head injury or brain injury. A small number of the population exhibit unequal pupils and isochoria. Causes of depression. Causes of depressed brain function include the following: injury of the brain or the brainstem, trauma or stroke, brain tumor, inadequate oxygenation or perfusion, abuse of drugs or toxins being present in the body. We will use the Pearl mnemonic to describe the pupils. Pupils equal and round, regular in size, react to light. We will also evaluate the neurovascular status. So consider the GCS, check the pupils, and evaluate neurovascular status. A neurovascular assessment is required if you suspect a limb injury or a spinal injury or a patient who has had a stroke. So this is where we will check the pulse, the sensory nerve, and the motor nerve. And when we do a pulse evaluation at this point, the rate of the pulse is not important. We're trying to determine if circulation is still present. Can we feel a pulse? Is it weak or strong? That's the purpose of the pulse check in the neurovascular status. You shouldn't have to be checking a rate at this point because you should know the rate of the patient's pulse already in your circulation. So the neurovascular assessment is for a suspected limb injury, head and spine injury, or a stroke patient. Remember that. Check for bilateral muscle strength and weakness. Complete a thorough sensory assessment. Test for pain, sensation, and position. Compare distal and proximal sensory and motor response on one side with the other. Now for your anatomic regions, head, neck, cervical, spine, palpate the scalp and skull. Check the patient's eyes. Check the color of the sclera. Assess the patient's cheekbones, check the patient's ears and nose for fluid. Check the upper and lower jaw, maxillae, mandible. Open the patient's mouth and look for any broken or missing teeth. Note any unusual odors in the mouth. For the chest, inspect, visualize, and palpate. Watch for both sides of the chest to rise and fall together with normal breathing. Observe for abnormal breathing signs. For the abdomen, palpate for tenderness, rigidity, and patient guarding. Use your 4 quadrants. Left upper, left lower, right upper, right lower. And you always compare left to right or right to left. Always compare bilaterally. For the pelvis, inspect for symmetry and any obvious signs of injury, bleeding, and deformity. For the extremities, inspect for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate for deformities, check for pulses, motor, and sensory function. For the posterior body, inspect the back for DCAPBTLS, symmetry, and open wounds. Palpate the spine from the neck to the pelvis for tenderness and deformity. For your vital signs, assess your vital signs. So remember, for your secondary, you're either going to be doing a detailed, systematic head to toe or a focus assessment based on the system that is being affected. And you will be doing your recorded vital signs, or as I call it now, your post-treatment vital signs. So use appropriate monitoring devices. Should never replace your comprehensive assessment of the patient. So what that means is the devices that you're going to be using for your vitals, if they are digital devices, don't treat the device, treat the patient. So always focus on the patient presentation first, then look at what a device is telling you. So pulse oximetry used to evaluate oxygenation effectiveness. Very important tool for you to utilize, especially if you have made a decision to give a medical patient oxygen. You want to know what their pulse ox reading is on room air before you put them on oxygen, that you can know if they are improving or they're getting worse. Very important. Now, pulse oximetry is not exclusive to medical patient. You can use it with your trauma, but it's a very important tool for your medical patients who you deem require some type of oxygen administration. So pulse oximetry measures the oxygen saturation of the hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. Very important statement. So again, patient presentation must be considered before numbers. We don't treat numbers, we treat the patient. So if the patient is showing signs of hypoxia and the pulse ox reading is normal, we treat the hypoxia that is present. His presentation say give him high flow, give him high flow. Now, capnography, not very common in Jamaica, but it's a very useful tool for measuring ventilation, circulation, and metabolism. And it is a device that can also give a ventilation rate. So it actually measures the patient's ventilation as well. It will give you a rate that the patient is breathing at. And the normal values for the pulse ox is 35 to 45 millimeters of mercury. What did I just say? The normal values for capnography, which measures the amount of CO2 that's coming out of the patient, is 35 to 45 millimeters of mercury. So you have different measuring tools. You have colorimetric end-tidal CO2, which gives a color change. You have digital capnography. You have the digital one, which only gives a digital value, and you have the capnography, which gives a number and a waveform once it's connected to the cardiac monitor. If the patient end-tidal CO2 or capnography reading is below 35 millimeters of mercury, then it means that the patient is breathing too fast. If the patient's capnography reading is above 45 millimeters of mercury, the patient is breathing too slow. So remember, capnography measures the amount of CO2 that is being exhaled by the patient. So if a patient is exhaling a lot of CO2, they are breathing too fast. Sorry, if the patient is exhaling, breathing off a lot of CO2, then their CO2 level is going to drop in the body. That's going to be below 35. If the patient is not breathing off a lot of CO2, then their CO2 level is going to rise within the body. And that means the patient is breathing too slow. So pulse oximetry measures oxygenation. Capnography measures the level of CO2 that is being retained or removed from the body. Blood glucometry or random blood glucose will measure the level of glucose in the bloodstream, which is very important when you have a patient with altered mental status or a patient who is not responding. Glucometer reading is going to be very important. The millimoles per liter is commonly used in Jamaica in your textbook, and in the US, milligrams per deciliter will be the reading that is commonly used. So you need to know what the normal blood sugar reading is in milligrams and millimoles. All right, not gonna focus too much on blood pressure. All right, now after, hold on, let me back up a bit. Now, if you're using a digital BP cuff, because most of the equipment is now digital. If you're using a digital BP cuff and you get an abnormal reading, you need to check it manually. Because sometimes the digital devices can be incorrect. All right, now after we have completed the secondary assessment, the final part of the patient assessment process is going to be the reassessment. The reassessment, this is where you are going to repeat your primary assessment, but we're repeating the primary assessment with a goal in mind. So you're going to repeat your primary assessment, you're going to reassess your vital signs. If you have a critical patient, you should have at least 3 sets of vital signs before you reach the facility. Might not be possible in all cases, but that should be a goal. That will give you a good idea of whether or not your patient is trending up or trending down. So in your primary assessment, you're going to repeat your primary. Sorry, in your reassessment, you're going to repeat your primary assessment. You're going to reassess your vital signs. You're going to look for trends. Is your patient getting better? Is your patient getting worse? Is the treatment working? What do you need to change? Do you need to step up or step down? Very important. You will also be doing documentation in this area of your patient assessment, and you will be using whatever method is approved by your organization. So it can be you are reporting in chronological order, it can be you're using the SOAP method, it can be you're using the chart method, and you're going to notify the receiving facility, and it's going to be based on what the patient told you, what your assessment revealed, what you did based on your assessment, how the patient respond to your treatment, method of transportation. So reassess the chief complaint. Ask and answer the following questions. Is the current treatment improving the patient's condition? Has an already identified problem gotten better, or has it gotten worse? And if it's getting worse, what do you need to do? Is it something that is within your capability, or you need to now rendezvous with ALS, or you need to now notify the hospital that, hey, this guy presentation has changed to XYZ. What is the nature of any newly identified problems? Recheck your intervention. So check all intervention. Most important are the patient's ABCs. Ensure management of bleeding, ensure adequacy of other interventions, and consider the need for new interventions once it's within your scope of practice. Identify and treat changes in the patient's condition. Document any changes, whether it's positive or negative. Document and ensure that you document properly. Reassess the patient. The patient is unstable every 5 minutes. Patient is stable every 15 minutes. And that would be the end of the patient assessment chapter.